Good afternoon, folks. Thank you so much for joining. We are going to get started. My name is Sarah Rahim, and I am a program manager at Interfaith America. We're so excited to have you as part of today's conversation titled Mending What is Broken, Spiritual Caregiving, and Health Worker Resilience. Today's conversation is co-hosted by Interfaith America in partnership with Chaplaincy Innovation Lab. You'll hear more about the lab in just a minute from Michael, and I'll take some time to introduce Interfaith America for those new. So Interfaith America is the nation's leading nonprofit working to promote understanding and cooperation across religious differences. We believe our nation's religious diversity is a strength that can be unlocked to promote civic engagement from classrooms to boardrooms to exam rooms. So in short, we inspire, equip, and connect those committed to engaging the positive potential of religion for improved health outcomes. And most importantly, we are thrilled to welcome you all today. So before we get started, I'll take a minute just to call out a few things on our webinar. On the bottom of your screen, you're going to see a Q&A feature. This is going to be available for you at all times over the course of the hour to add in your questions for our wonderful panelists. So because there are so many folks on the call, if you pose a question in the chat box, we may not be able to see it. So if you have any questions, which we'll have time towards the end, please do post that specifically in the Q&A. And great to see folks welcoming each other and introducing yourself in the chat. I encourage you to continue to do so. So now I'm pleased to pass it over to Michael Skaggs, Director of Programs at Chaplaincy Innovation Lab.
Thank you very much, Sarah. And I do want to note, I see a couple of folks noting that they're having trouble with the audio. I'm sorry. I wish there was something that we could do about that. That is usually something on your end, though. So you may have to kind of poke around in your Zoom settings in the audio to see what's going on there. It's just not something we have any control over. So I'm very pleased that we are partnering with Interfaith America on this webinar. It's a series of webinars, and this one, of course, is focused on resilience in healthcare. And so I'm happy to introduce our guest, and then I will turn it over. Dr. Jesse Gold is the inaugural Chief Wellness Officer for the University of Tennessee Health System and Associate Professor of Psychiatry at the University of Tennessee Health Science Center. She works clinically as an outpatient psychiatrist and focuses her work on students, faculty, and healthcare workers. She has spoken at major national and international meetings, but she may be best known for her general audience publications that teach about mental health topics and decrease stigma that can be found in, among others, the Washington Post, the New York Times, Forbes, Self, and In Style, as well as her expert media appearances in print, television, radio, and podcast, and her large social media presence. And I'm very happy to note that Jesse has a book that's going to be hot off the press very soon. We will have a webinar on that book in October. And as soon as that book becomes available, we're going to select some folks at random from this event today, and it's just going to show up at your house. Actually, I guess I need to ask you for your address first, but I'll be in touch with folks, and we'll send out a couple of copies of the book. During medical school, it became evident to Pallavi Tadapudi that psychiatry was not a choice, but a calling, drawing parallels to the natural fit between revered Hindus revered figures in Hindu mythology. I'm sorry, Pallavi. She found inspiration in the field's emphasis on effective communication, mutual respect, and unconditional positive regard. As a lifelong student of Vedanta, a philosophical and spiritual tradition within Hinduism, Pallavi's journey was shaped by teachings from Vivekananda Vidyapith in Wayne, New Jersey, from which the pillars of prayer, service, and respect became integral to her profession. She continues to explore creative expressions like poetry and dance to understand and process patient experiences. And then finally, Tanya Willis Robinson is the Director of Spiritual Care and Chaplaincy for the West Central region of Indiana University Health, go IU. She is a board-certified chaplain through the Association of Professional Chaplains and on the board of directors for APC. She graduated from Marian University with a degree in religious education and went on to receive a Master of Divinity at Bethany Theological Seminary. Tanya completed her internship and residency at IU Health, Riley Hospital for Children, and Methodist Hospital, and has been with IU Health for the last 10 years. She is passionate about the work she co-leads for resilience in stressful events, which is the name of a program that we're going to hear about here very soon. So welcome all of you. Sarah, back to you.
Thanks so much, Michael. So first, we're going to hear from Dr. Jesse Gold, who's going to provide an overview of the broader landscape of mental health, specifically in the health worker space, as well as trends and approaches that we're seeing in this area. So Jesse, over to you. Do a spotlight right now.
Okay. Hi,
Thank
everybody.
you.
I'm gonna apologize ahead of time and say that my voice has a little bit of like a raspy quality due to having pneumonia. So I apologize for that. It doesn't exactly practice what I preach, but that's part of the fun of everything that we do, isn't it? I have slides somewhere.
Yes, we will have Zia open them right now.
Okay. I made slides mostly because giving you an overview of all of these topics off the top of my head felt like I would bore you and you would be like, oh, I'm taking notes, but not really listening to her. So I put some stuff up here just to get on the same page. So it was mentioned. So I'm a psychiatrist. I see healthcare workers primarily. I also am a chief wellness officer. So in that role, do a lot of administration around well-being, education, research, and programming now for the basically entire state of Tennessee's schools. So that's 5 different schools under me. But to kind of get us on the same page with words, because I think that's a big issue, especially in mental health, because a lot of words have been kind of colloquially like used in ways that we don't necessarily mean them. So I think when we talk about burnout, a lot of times people just mean like work is tired, I'm burnt out. But really what it means is this kind of constellation of 3 things, which is emotional exhaustion, which can look a lot like physical exhaustion, depersonalization, which in healthcare or in interacting with other people is sort of like you're going through the motions and not as connected, your empathy's down. Sometimes they use the word cynicism for that one, but that's just like anger instead of disconnection. But I'm sure we probably can resonate with both of those. And the last one is a reduced sense of personal accomplishment. So like you're getting less done, you feel like you're getting less done, you're feeling ineffective. That's the one that people tend to notice. The other 2, I feel like people go, well, I'm supposed to feel emotionally exhausted. I'm a chaplain. I'm supposed to feel emotionally exhausted. I'm in healthcare. I'm supposed to sometimes feel disconnected because they taught me that's how I like should cope, right? Like if I'm too connected to what I'm listening to, I'm not going to cope because I'm going to hear it and feel it and hear it and feel it. And I can't do that. So we think of depersonalization like a coping strategy. But the last one, that's the one where like someone might notice we're not doing our work, or we might notice we're not doing our work, and that bothers us. So that tends to be what flags people, at least in my experience clinically. Another way you can think about it is a mismatch between what you think work is going to be and what work actually is. So like we think work is going to be helping people all day. Work actually is charting a lot of the time, right? Nobody's like, I really want to be a healthcare worker to write notes all day. But that's what it ends up being. And that mismatch is where burnout is, a lack of meaning and purpose in what you're doing. In healthcare, across the board, sort of depends on who you survey, who you ask, what you're asking, but about 50% of people are burnt out. And that is bigger than other people in similar professions and similar schooling and all of that stuff. Next slide. I think. So then you're like, okay, so that's pre-COVID, right? And I'm not going to like harp on COVID for too long, but I do want to say, and it shouldn't surprise you that made things worse. I think it tends to be framed like this COVID fairy came down from the clouds and made everybody sad. And that's where we found burnout and depression in healthcare. And that was not at all the case. We were very unhappy and very burnt out. And then the COVID fairy came down from the clouds with different stressors and made us more burnt out and more sad, right? So that's how I think about it. It's as a result, when someone magically says, well, there's no more COVID, it doesn't mean there's no more burnout or we're fine, right? It probably just means we're worse off. Next slide. I like to think of it this way, which is like we talk a lot about the medical footprint of disasters, particularly COVID. We've spoken a lot about deaths and outcomes in that way. And I'm sure you deal a lot with that in what you've been seeing and in your work. But if you look at this is how you kind of can think about an impact from a disaster. That little footprint is the medical one. The big one is the psychological one. We spend a lot of time on the medical one. So the medical one for COVID is probably that big foot anyway, right? But for the way we think about it, like that means that there's a lot of people who are affected in their mental health. That means the people doing the work. That means the patients that you're seeing. That means your colleagues, right? So this is very pervasive, and it's not something where it's like going to come out tomorrow and that's the only time it can come, because trauma has like no timeline, right? So we could see this at any point. So that's important too. Next slide. We're starting to see that in numbers, like just so you can see kind of where we are, like in what they're looking at in healthcare worker numbers. Burnout for them before was 32%, went up to 46. Harassment has doubled. I think we're seeing that in a lot of people in the field and sort of what patients are bringing into the setting and how that has been, and also within the workplace environment. And that's obviously not a good sign. Then the trust in management has gone down. So if you don't like feel supported by your workplace, you're also more likely to burn out. And then this number, this turnover intention, I think is a big thing to be thinking about for sort of like the future of healthcare, right? Which is if 44% up from 33% of people are saying they might leave their jobs, when we're already in a place where we don't have enough providers, like where does that leave us? And oftentimes people kind of sit in their jobs for a long time before they even say they want to leave. It's a big thing to want to leave because our identity, our money, our time, our schooling, our social life is all wrapped up in work, right? And without that, like who are we? Even saying we might leave is a big thing. So that's a big number. Next slide. Another concept I just want to like quickly touch on too is this concept of moral injury. You might have heard this in your workplace too. It wouldn't be surprising if you have. Moral injury is different from burnout. It's more about the like morals and values aspect than burnout is, but sometimes the symptoms look very similarly. This QR code can take you to an article like in a popular press that I wrote about it, if that would help, but that's what it's there for. Next slide. But really what this term was is they basically were like, how do we say we're not going to call this PTSD? And it's something different than PTSD that we're experiencing. And what it is when you engage in or don't prevent or witness something that goes against your values or beliefs. And this happens all the time in healthcare. So there's lots of different examples on here, like making a decision that could affect survival, which we maybe saw with things like machines and are there enough machines, doing something that goes against your beliefs. Maybe there's something that politically is being changed in how healthcare is run and that goes against your beliefs and you have to wait till someone's sicker. Failing to do something that goes in line with your beliefs, like helping someone when you feel like they should be helped. Sometimes it's as small as something like, for me, every day trying to get ADHD medication has been really hard. And that feels like it shouldn't be something that causes moral injury. But if you think a patient needs a medication and there's a shortage, that can like add up over time, right? And that injury part is how we feel afterwards and how it kind of pervasively affects our lives, including spiritually. Next slide. And basically what this looks like is a stress reaction. So changes in sleep, changes in behavior, feeling isolated. Overworking is big for us because if we work, we don't feel, right? We just keep going, we just keep going, we just keep going. Big feelings there being guilt and shame and anger. And sometimes that can lead and linger and look like PTSD. Next slide. If you kind of think of it this way, kind of conceptually, like the left side being burnt out, the right side being moral injury, at least my right and my left. So if you look at kind of where it's coming from, you can see that like the way it originates is different in that it's a violation of a moral belief to get to moral injury. That's something that comes from the cost of how you care. And then the other ones, the burnout is really about the workplace, hours, burden, workload, not feeling trained. And you can look the same and the kind of symptoms might look the same. You might even have both, but they're coming from different causes. Next slide. Another thing I just want to add is it's not a resiliency or fault of resiliency. So we made a mistake, or someone made a mistake because it wasn't me, a while ago in framing like, let's fix the healthcare problem with resiliency. What they meant to say was like, hey, when there is a system that is broken, to survive it, to work in it, to be able to deal, you need some skills. But they framed it like your answer is to fix you, and that never went over well with people. And as a result, that word makes most people in healthcare cringe, especially because if you look at the data, we're more resilient than most other populations. And even the most resilient people are still burnt out. So it can't be resiliency. Next slide. So briefly, I just want to say, like, this is how I think about it. So it's the system has a lot of problems and the culture has a lot of problems, but the system itself and the thing that we work in, I like this quote because it is really impossible for us not to be affected by our work. It is wrong to assume we could because it's actually impossible to not be. Next slide. When you look at the fact that we should obviously need help, but we don't ask for it, we say, well, like, okay, well, why? And it breaks down into sort of systems things and culture things. Systems things, I think, are across the board in mental health, but even more so in healthcare. So like time off, can't get off work, can't afford it, too busy. Those things make a ton of sense. But there's a reason why 20% of people thought they needed services and didn't. And it's not just time and money, though that's a big thing. But if you think about it just being time and money, you're just going to be frustrated at people like me in administrative roles and feel like we aren't doing anything. The thing we can change is that culture part, the afraid or embarrassed to seek care part. 17% of people saying that they can't get care, they don't feel like they can, right? That part is the thing that we can do for each other, the way we treat each other, the way we talk to each other, the way we talk to each other about this. And this is where a lot of people come who are like, going to see the chaplain on the service because they don't want to come see me because they're embarrassed to see me, but they feel more comfortable seeing you. But then that's a burden to you because that's not necessarily what you're there for. And that's a big burden to have to hold to do that for a whole team, especially a team in the height of the pandemic. Next slide, if I have time for it. One more click. Go one more click. You can have that slide later. The thing I just want to frame here is that we've like the way healthcare and the way our culture is and the reason we don't like asking for help is kind of twofold. One is that we've normalized being ill. So like when you look at people who do a study and they say, well, how well are you compared to other people? People in the bottom think that they're at average or above average about 71% of the time, meaning you can look next to you and say like, that person's not sleeping, so that's good because I'm not sleeping either. Or that person looks a little more sad than I am, so I'm doing well, right? But just because like our comparison's off and we've normalized not sleeping, not eating, and not functioning does not actually mean that's good. It just means we're in a pretty sick kind of culture. And as a result of that, when we think we need help, we think we're somehow worse off than other people. And that's within the same context of sort of like imperfection and feeling like we're competing with each other all the time. Because if asking for help is an imperfection or asking for help makes us stand out, then we don't want to stand out in that way. We want to win because they told us we need to win to get into these programs, to get into these spots. So if we ask for help, it is a failure, a moral failure, just failure that is not something we're prepared for, and it feels worse when it happens. So that's my ability to sort of frame this as good as I can in like as many minutes as that was. Burnout, moral injury, where healthcare workers are, why that might fall to you, and how you fit in within that context.
Great. Thank you so much, Jessie, for just providing more of a general context or just doing level setting for us really in terms of context for this conversation. As you mentioned, defining moral injury and burnout in health workers, but more broadly, just healthcare culture, as you mentioned, around seeking mental health care. So now we're going to do a bit of a pivot and hear from two more personal kind of on the ground perspectives, starting with the role of chaplain as a provider of spiritual care, and just more specifically, how that works to create health worker resiliency and just prevent some of the issues that Jessie defined for us. So I'm pleased to introduce Tanya Willis-Robinson.
Good afternoon. Thank you, Sarah. Can you hear me okay?
Absolutely. I will
All right.
spotlight you in just a minute. And are you able to start video?
Yes.
Great. There
All
we
right.
go.
Thank you. Hello, everyone, for being on here. And just want to say I'm coming to you from the lens of a chaplain. And oftentimes, chaplains, we have the ability to be the pulse of many institutions and really know what's going on with our team members when they are burned out, when they're experiencing moral distress from different situations, from our connections with the interprofessional team and to the interdisciplinary team, from roundings and huddles, we get to hear their narratives and their stories of what's really going on with them. And it's a way to really advocate for our team members. At IU, we use Dr. Leslie Tarkey and Shelley Berner Perez develop what we call the SKY framework, which is spiritual care assessment and intervention. But I found that it's also helpful to use that same assessment tool to see really what's going on with team members that I'm supporting by asking them the different dimensions of their meaning and purpose, finding out what's going on in relationships with them, what speaks to their very core, their beliefs, their values. And in doing that, I can make informed decisions of how I will collaborate with their leadership to help undergird them during times of stress, during times where we need to pivot and send in for referrals. And that's another segue to what I do. I also sit on the ethics committee as an ethics liaison. And oftentimes I see a lot of moral distress going on with our team members from different decisions they have to make. And how do we undergird people that are making tough decisions every day? Dr. Naomi Riemann would say, offer generous listening as we're coming up with recommendations to give to a team that's already struggling. We also have what we call team-based spirituality, which was a project started to help generalists work and partner in tandem with the chaplain, who's the specialist, to identify things going on spiritually with patients. But that same resource is good to use for teams as you're building them. Finally, I am part of and co-leading what we call the RISE program, Resiliency in Stressful Events. Our RISE team, we're all trained in crisis intervention and as well as crisis intervention stress management. We go to do debriefings, we do peer-to-peer support. This is something that we make leaderships aware of so that when team members are feeling like there's no support for them, they can call a RISE member. We are fully staffed. We have revamped our program and did it within less than 9 months to where we started with 5 staff and now have 30. We respond to crisis 24/7. We're there to undergird team members that are experiencing traumatic events within the hospital, outside of the hospital. We do debriefings, we do blessing of hands, we do whatever is needed so that that staff person can return to what we would call their cognitive thinking brain. Oftentimes when people are experiencing traumatic events, it causes them to be paralyzed, to really have to pause. And a peer-to-peer support person will come along and just deal strictly with the emotions of what's going on with an individual and see how we can help them to at least return to that baseline to where they feel supported. I want to say 4 months ago, we was dealing with a whole unit that specialized in complex care. They had several cases that happened that doubled within a matter of 2 months. And the team felt like they needed just somewhere to be able to discuss what was going on. We created a brave space to allow the team to really disclose their feelings. The manager of that unit said that was the best thing for her team. There was so much positive feedback for how the team felt supported. The next day, we offered a blessings of hands just so they could be rejuvenated about their work. Sometimes we're looking for this overall fix and it's not going to happen. But when we can really just tap into someone's humanity and offer this over what we like to call unconditional positive regard for the other person, it means a lot to someone that's going through who feel like they're isolated and alone in their feelings. It's important to let people know they're not alone in what they're dealing with. Our team is built up of physicians, caseworkers, case managers, nurses, chaplains, dietary workers, and that whole team collectively coming together, we're able to offer the support that we do throughout the West Central region. And we take pride in it. And I hope I'll leave you with this one question that Mary Oliver said: what will you do with your one wild, precious life? And with our one wild, precious life, we try to help our team members remember their value, to remember their worth, and to remember their vocation that they're called into. Thank you. If you have any questions about any of the models, my name and number is on here, and I'm happy to help you with implementing them into your institutions to help build your teams up. Thank you.
Thank you so much, Tanya, for sharing a bit more about just the grounding of spiritual care and the role of chaplain to really support health workers and minimizing burnout. I'm pleased to pass it over to our final panelist before Q&A, Pallavi, who will speak just to her own personal narrative as a health worker navigating the space of COVID-19 and beyond, and just her experience with engaging with spiritual care, as well as her own faith background and how that influences her role as a provider. So Pallavi, over to you.
Thank you so much. Namaste and good afternoon, everyone. I wanted to first start by saying, the webinar in March, that was wonderful, and it was focusing on whole person care. And I'm really, really thankful to be a part of this collective experience today and for this chance to connect with all of you across the health ecosystem. And I'd like to start with a mindfulness practice. It's called Leaves on a Stream. And this is how I begin my presentations and meetings at work and personal life. And it helps me approach my work with great love, I would say, attention, presence of mind and heart, and to not be attached to the results of the work. And when I was thinking of what I'd like to communicate and share today, it felt very natural to start my time with you all this way too, to kind of show first in action. So I invite you all to join as you feel called to for Leaves on a Stream. Start by sitting upright in our chair, putting our hands comfortably on our lap, and if we want to and feel comfortable, to close our eyes. Remember, our task is to simply observe any thoughts, feelings, sensations, or urges that we may experience in our body. I want us to imagine that we're standing on a bridge above a stream. Floating on the stream are leaves from the surrounding trees. This may be a stream that we actually have been to before, or maybe one that's near our house, or maybe one that we just imagine. Take a few moments to observe what's going on around you and what is happening within us. And remember, observing is just looking around. It's not attempting to label, describe, or respond in any way. Now, let's label what we observe without letting judgments get in the way. So for each observation that we make, we can label it as a thought, a feeling, an urge, or physical sensation, and then put it on the leaf and let it float down the stream. So we may have a thought about something that comes up. It's okay. Label it as a thought, put it on the leaf, and watch it float away downstream. Other things we might experience, maybe our body sensations, how the chair feels under us, feelings we're experiencing, or maybe even distractions going on around the room, next to our room. Label each one, put it on the leaf, and let it drift down the stream. And the important thing to remember is to not go down the stream with the leaf, but rather to stand back and let the leaf drift off. If we notice our mind wandering off, gently notice where your mind is. What were we thinking about? Describe the distraction, put it on a leaf, and watch it float away downstream. Now slowly, when we're ready, bring our focus back to the room. We can feel ourselves sitting on the chair, or if we're sitting on a couch or on the floor. Listen to any sounds that are in the room, and slowly, in our own time, begin to open our eyes and rejoin as a group. So thank you so much for starting with me that way. And a question that we can kind of sit with for a second is reactions, right? Responses. How did that feel? And that's an internal question. You could put it in the chat as well. For me, I could share I feel calm, I feel excited, and I feel ready to go forward. So thank you so much. I'd now like to share a little bit more about like a personal introduction. So I speak today. Thank you so much. I see the comments in the chat. I speak today from various different lenses, some of which include being a devotee of God who practices Hinduism and Vedanta, a doctor currently in child and adolescent psychiatry fellowship training, a community member, and more. And to introduce myself, I grew up in Suffern, New York. I attended public school growing up, and I also attended Vivekananda Vidyapit, which is a character building institution of Hindu culture and philosophy. And I was there from kindergarten till 12th grade. It was started by Drs. Mahendra and Vandana Jani, who we lovingly call Uncle and Auntie, and have stayed connected as an alumni since. The pillars of Vidyapit are prayer, service, and respect, and they're based on the teachings of Sri Ramakrishna, Sri Sharda Devi, and Swami Vivekananda. And so I then went on to college at Georgetown University, a Jesuit institution that's focused on many values, including cura personalis, or whole person care. And I also here just wanted to mention the Ignatian Examen. That was a prayer, a very helpful prayer to me that I was introduced to, that I've added into the Hindu prayers that I engage with. And for those of you who are familiar, praying the Examen is kind of placing ourselves in God's presence, giving thanks, praying for grace, to see how and understand how God's acting in our life, kind of reviewing the day, reflecting on what did we do, what did we say, what did we think in different instances, where were we drawing closer to God, where were we further away, and then looking to tomorrow, or looking to that next moment, and how can we collaborate effectively with God's plan. And during college is when I became part of Interfaith Youth Corps, now Interfaith America, and since then have stayed affiliated. And then I went on to Stony Brook for medical school. I completed adult psychiatry residency training at Stony Brook, and now I'm in child and adolescent psychiatry fellowship at Stony Brook. I'd like to share a few anecdotes from my personal experiences from my psychiatry training. So it occurred mostly during the pandemic. COVID was surely, an isolating experience for many. I think folks in healthcare, patients, families. And I think with the social distancing, I also noticed that there were less smiles exchanged. I think more distant environment, more sterile, cold at times. And I think training during such a period really certainly had its challenges. And I contrast this with the recent solar eclipse. That was fascinating. I saw the whole kind of hospital community coming together, People had extra eclipse glasses that they were willing to share and give out to people so that many people could enjoy this event. And people came outside during the workday to be in nature together, to be quiet, and to be in awe. It was a beautiful thing to see. And I also contrast the COVID experience with the recent earthquake. So I didn't feel the trembles from the earthquake myself, and many others around me had. And the hospital, again, it was buzzing. People were looking up. They were away from their devices, making eye contact, engaging with each other. And it was fascinating because the connecting paths, we have a health science tower in the hospital, the connecting paths between them were closed. So people had to come down on the elevators to the health science tower lobby, walk the path to the hospital lobby, and go up the hospital elevators. So there was way more traffic, and also people were interacting who had never spoken before. People were checking in with each other to see if they were okay. That sense of community increased, and the joy, the connections were so palpable. And next, I'd like to share a little bit about how I actively mend what is broken, which ties into our theme. I think at a personal level, how I spend my time, I try to do so very intentionally. First is with regular prayer. That's a very important pillar and grounding part of my life. And then at Vidyapit, we just actually celebrated Buddha Jayanti, which is the birthday of Lord Buddha, earlier in mid-May. And one key lesson from Buddha is about being good and doing good. And I'll actually show you this. In my fellow office, I wrote this on the Post-it, and it helps me remain really clear on my values as I go about my workday. I think also participation in different leadership programs and community-based programs that really highlight diversity, equity, inclusion, belonging, accessibility, justice, these types of values really are the kind of the mainstay that keep me and my motivation fueled. So a few I'd like to share. One is called the House Staff Emerging Academy of Leaders, also known as HEAL USA. It's hosted by UT Southwestern, and it brings trainees across the country together to dig deep into our visions for ourselves, how our values can shine, and really the emphasis is on taking action on our goals. And the second program is called the HOPE program, which is a lovely word. It stands for Health Occupations Partnership for Excellence that Stony Brook Medicine has. And it's a free after-school program offered to many students at Brentwood, Longwood, Wyandanch, William Floyd High School, so across Long Island. And being a part of that program as a mentor and talking about psychiatry, psychology, and what these careers can offer students in high school and potentially help them with their interests is really meaningful to me. The next one I'd like to share is about LEND. There are many LEND centers around. LEND stands for Leadership Education in Neurodevelopmental and Related Disabilities. And that fellowship, I would say, is the most meaningful interdisciplinary learning environment I have been in thus far. And the fellows that are in it represent many fields. So you have core disciplines, self-advocacy, adult medicine, child medicine, dental medicine, disability studies, family, nursing, occupational therapy, physical therapy, psychology, public health, social work. So the conversations were so rich about how we can improve the lives of autistic individuals, families, and those with neurodevelopmental disabilities. And one really, really meaningful activity I'd like to share with you all has been to review the code of ethics, the oath that, say, each of us has taken for our professions, and personalize it, infuse it with depth, intentionality. And I think doing this with other team members across disciplines has been fascinating and a very, very revealing experience. And I'd urge those who are interested to consider it. Now, during the workday, how I stay connected to uplifting values. So I love quotes, so I have a bunch of Post-its around the office. I have my board back here. One of my favorite cartoons is a monk holding a sign that says, "The end is in sight," and there's no space between in and sight, so it's the end is in sight. And I love that. I think I wanted to share too that I think being around uplifting ideas, right, from quotes or inspiring books can be very helpful to me. For example, there's a book titled "You Will Be a Paramahamsa" by revered Swami Sarvagatanandaji, and he writes many awesome things. And one of the points he says is, like, why is a hospital, and something for all of us to think about, why is a hospital called a hospital and not called, say, a sick home? Think about it for a sec. Because it's a place of hospitality. Why is a patient called a patient, not a sick person? because they teach us to be patient. And it's not about whether it's 2 minutes or 2 months of service. That's not the point. It's not really like the duration of service that counts. It's the quality. So if we meet somebody in the hallway for 2 minutes, for 30 seconds, or we're rounding on them every day for the next 3 months, it's not about the duration. So how do we practice that unselfish service? For me, asking patients and families about supports in the community, if they're part of a community that's maybe very meaningful to them, about their spiritual needs has been a key part of my practice as a psychiatrist. Being mindful of holidays, religious observances, and trying to help patients be able to carry out those practices comfortably. And for me, really connecting with chaplains, and I see so many present here, and being able to connect with chaplains in the hospital, for me personally and to my patients, has been one of the most wonderful experiences. I think that there's a great sense of spirituality present in many medical settings, like in the PICU, right, pediatric intensive care unit, working with palliative care teams. And I think that all of us kind of coming together and being able to restore each other and see what experiences we are a part of. We often meet people on their hardest days of their lives. So I also wanted to share about a gem that we have in our hospital. We have a wellness walk. So it's a 1 mile path in the Health Science Tower. And if you do 4 rounds, it equals 1 mile. And we also have a labyrinth on the Esplanade patio. That's a reminder to engage in mindfulness. And these are lovely ways, just tangible ways that we can stay active and stay connected. And we also have a wellness champions program, as well as code lavenders, right? Hospitals have many different codes for different emergencies. Code Lavender is one that's been instituted as a way to support healthcare teams when there's been a challenging, difficult, maybe situation, and to give kind of support to the team. And so it's something to think about in other places as well. And then the last one I'd like to share is going to the chapel in the hospital. It's such a safe haven, and I'm thankful to Georgetown too for the opportunities that it provided to me to worship on campus, to find solace in places of worship on campus. And I think that nook in the hospital is a really precious place. So I'd like to end with this. Many of you may have heard this. It is footprints in the sand. So let me bring it down here. So I'll read it to you from here. One night, a man dreamed that he was walking along the beach with God. Across the sky flashed scenes from his life. For each scene, he noticed 2 sets of footprints, one belonging to him and the other to God. When the last scene of his life flashed before him, he looked back at the footprints. He noticed that many times along the path of life, there was only 1 set of footprints. He also noticed that it happened at the very lowest and saddest times of his life. This bothered him, and he questioned God about it. God, you said that once I decided to follow you, you'd walk with me all the way. But I've noticed that during the most troublesome times in my life, there is only 1 set of footprints. I don't understand why, when I needed you the most, you would leave me. God replied, my child, I love you, and I would never leave you during your times of trial. When you have seen only 1 set of footprints, it was then that I carried you. And so I'd like to end with that. This poem really resonates with me. It guides me in my life, personally and professionally. So with that, I'd like to thank you so much for the chance to connect with each of you on this precious topic, and I look forward to staying connected. Thank you.
Well, thank you all so much for just a wonderful, variety of perspectives on, an enormous problem. And 3 perspectives are not nearly enough to get our arms around it completely, but this is certainly a good starting point. I want to transition now. We have plenty of time for Q&A. So if you have questions, please put them into the Q&A function rather than chat. That just allows us to keep a little bit better track of that. Lots of questions, so we may not have time to get to all of them. I'm very sorry, but we'll answer as many of them as they can. Joseph, a great question on kind of the dynamics of units and departments within healthcare. And Joseph says, when care staff, and I'm assuming, Joseph, you mean people like environmental services, security, etc., is intentionally treated as disposable or replaceable in an organization, how can we address that without being disposed of or replaced ourselves? So this is a resilience question. It has to do with job security, and that's a really great question, Joseph. I'm going to open it to all of you for how you have kind of squared this circle in your systems.
It's a great question. I can add one comment, which is that I think being able to have a space to really talk and have that support in a place where it can be received is really important. And I also think that being able to, in community with others, bring up in a curious, like not conflicting way, bring up these key points so that there can be systemic change. And so seeing who else can align and being able to go as a, like in a cohort and be able to maybe present the information.
I would say like a focus on control can be helpful in these situations. Serenity prayer wise, if that's how you want to go, but really like a lot of this stuff is big embedded systems and structures that have existed for a long period of time and are going to take a really long time to dismantle. And that's frustrating and really annoying. And at the same time, people like me are like, working on it, but it doesn't mean I can change it tomorrow, even working on it. And so I've found that when you think a lot about the system, you just get more and more mad. And so it is helpful to like acknowledge that, have the person to support you, and acknowledge that with ideally some colleagues who you can like debrief and talk about those things with. But at the same time, find some spaces where you can regain control in that environment, even if they're little things. Like, is there somewhere where you have one meeting you hate and one meeting you like, and then the rest of the day is miserable? Can you move the one you hate to like that day? I don't know. Like, can you move one thing, give yourself 5 minutes time in between a meeting to debrief and like have some space for yourself? Can you walk a hallway when you wouldn't otherwise? Are there ways that you can just sort of like regain some control of your day? I've often found too that people will get rid of the stuff that they get the most meaning and purpose for because they feel like they're full, like they can't take on more. But oftentimes people get meaning and purpose from things like mentoring and things like supporting other people, but they're like, oh, I can't do more. So paying attention to like, is the drive to not do more just because you're feeling so overwhelmed, but if you did it, you'd actually feel better, and be like mindful about where you're saying your boundaries are, because boundaries are great and you should say no more, but sometimes we make the mistake of saying no to the things that actually give us energy and give us meaning and give us purpose, because we're really just trying to do less overall. And so being more mindful about that, I think, can be really helpful in a system that feels really out of our control.
Excuse me. Thank you, Joseph. And I apologize. I noticed that I went very fast, Michael.
No problem. No
Trying to
problem.
be resilient, right? I wanted to answer that question, Joseph, with for my team, because the system is often broken and it's not a quick fix to come up with something. But what we can do as leaders, as I try to tell my team, is work-life harmony. Balance will not happen in the system that we work in often, but finding what gives you joy, the tweak schedules. For one of my staff members, from 5 days a week, we went down to 4 days a week so that he could have that extra day to kind of just take time for himself, for his family, and then have the weekend to do whatever they were doing. And he said that made such a difference. Rounding with our teams, and just, we have what we call tea carts. And I know some people may not care about gorditos, but when you're having a bad day and someone comes along with those, it makes a difference. But I tell the staff, as chaplains, we need to start first at home. We pour into our chaplains so that they can pour into the hospital systems, so that people can feel valued and see worth, even when they do feel disposable. Taking moments just to do reflections and readings makes a difference in how people see their day as well. Thank you. I hope that helped. and always seek harmony, because balance will not happen.
Really, Tanya, I wanted to add one little comment because it's such a good question, which is that perhaps writing, you know, like when we are, say, in a certain position, writing even a letter to ourselves of what would be helpful, and if I am in that leadership role that I'm not yet in, how would I lead and what would I do, so that when time passes and we are actually offered those opportunities, we remember that vision that was so clear to us before.
You know, Tanya, I love what you just mentioned about coming to this new arrangement with one of your staff members. And I think that is a reminder that, it doesn't hurt to think critically about things that many of us have received as unchangeable. The work week is 5 days long, right? That's what you're supposed to do. Well, for that staff person, clearly this position does not require 5 calendar days in that space. Now, of course, not everyone has the flexibility to change that, and not every structure can be changed just because we don't like it. But it is worth asking, do things need to be this way? And is there another way we can do them? And clearly, for one person, you have figured out a way to do that. Mary has a question about kind of the contours and the borders of moral injury. And Mary says, can moral injury be something done to us as well as something that we have done ourselves? That's a really good, just fundamental question there. So anyone who wants to speak on moral injury.
I was going to let someone else do it so you didn't have to be bored by listening to me talk about it. But I mean, I think yes, the answer is yes. I think it's like it's witnessing something. It's not being able to intervene in something. It's something happening to us. Sometimes I think hierarchy has a lot of moral injury just inherently bed into it, right? Like you're not supposed to do that because this is the way that we are structured and this is the person making the decision. But often the younger ones are the ones saying, stop, no, this isn't good, because they remember what patients and humans are, right? And I think that that's part of it too. So yeah, it's pretty complex in that sense, but I think it really can be on to you or witnessing on to others or witnessing happen and not being able to do something, which also matters. Does anyone else?
Yeah, that's such a lovely explanation. I wanted to add to that too. It kind of reminds me of the conversation of because when you witness so many things and feel that we're not having the agency, like we may have learned about the treatment that could really, really help this patient at this time, and we know medically that would be awesome, and then you can't get the medication for the patient, it's not being approved, they can't afford it, there's so many reasons, and then they get more sick. And like all of these kind of things can be really, really difficult. And I think it reminds me of the topic of microaggressions and of like things kind of we see and witness and experience. And I learned of this and I wanted to share it about micro affirmations being the other side of it. That when we do see moments that are wonderful and beautiful happening and unfolding, can we bring attention to that in the setting? And because oftentimes we are noticing all of the other sides as well, and having that balance of providing macro and micro affirmations could be really helpful.
This is an anonymous question. I think it's a really good one because this must be a challenge for folks that want to implement useful measures in their own facilities. And the question is, do you have any tips on how to help provide support for staff or team members who may have never experienced anything like a critical incident debrief or a mindfulness practice or whatever? They may feel uncomfortable or disinterested out of lack of knowledge. So how do you kind of get over that hump of, yes, this is something that it might make you feel kind of icky right now, but it's worth it in the end, or could be?
I was just looking at that question. So two things. At IU, we have started this conversation called a brave space, to where anyone is invited into that space where we are dialoguing about any complex questions, situations that have happened that people need to digress and dialogue about. We start with I feel statements, and you always have to respect how someone else is feeling. We suspend judgment of why others are feeling that way. And the more other team members heard that that was happening, the more other managers and leadership heard, hey, there's a team and they will come to you, it gains traction. And so once a month, we have this conversation for brave spaces for people to really discuss that. We also encourage people to have courage. It's okay not to be okay. It is okay to say you're hurting. It's okay to say you don't know. And so our team, that's why I think it's important to have a diverse team so that physicians see there's other physicians on the team, EVS workers, food ambassadors, just so many people. So when the team is diverse, there is someone who can relate to what you're going through. And I think that is part of the buy-in.
Yeah, I'm a big fan of transparency in these conversations, right? Like there's no point in pretending it's not going to be awkward, right? Like there's no point in saying like this is all super fun for everyone and we love to stop and feel. Most of us don't. It's scary. Even if we talk about it all day. I'm a psychiatrist. I talk about it all day. But even with that, I would rather talk about you all day than talk about me all day, right? There's a reason I chose to do that. So I think it's really important when you're framing this stuff, especially to healthcare workers and our coworkers and stuff, is to acknowledge the weirdness of that and the almost like it doesn't make sense that that's true, but it's true. We don't practice what we preach really well. And so like understanding that and saying that and naming that, I think is really important. I think framing is also really important in this group. So like it can help to say like, listen, you might sit here in mindfulness and not like mindfulness. That's okay. You might find something else that you like. I personally have tried mindfulness so much that I have like done a retreat for a whole weekend and I still don't like it, but I will tell patients it's an option because there are lots of options and there's lots of data. And so I think it's a framing thing too, right? Like we don't want to say the only option for this is to do mindfulness and meditation, but we want to say like, hey, try some of this stuff out like a skill, like a hobby. If you like it, you're going to do it. And that's what's going to matter. Right. And so I think it can help to frame too and be like, listen, when I tried that, I didn't like it, but you might, or listen, there's all these other things. Right. So I think that has helped in this group too, at least like as a doctor in this group and with my peers in this group too.
Definitely. I wanted to add 2.1 is that I think being able to kind of invite and not pressure is very important. So usually before meetings, what I'll do is let people know that a few minutes before the meeting time, I'll be logging on early to be able to offer this for anyone who'd like to come. And then, you know, we start the meeting right on time. So I think that just having like the space and just invitation, and also it might be helpful to ask people, okay, maybe not this. What has worked well for you? I'm willing to try that. Can you introduce me to what's worked well for you? And us also being able to learn and add into our toolbox any other things that people would like to share. That could be very wonderful.
This is a number of iterations of this question have come in, and this is actually going to be the last one, unfortunately. But of all the versions, this one kind of encapsulated all. How can we, it's anonymous, how can we normalize the struggle that people are feeling in this work and be vulnerable when others are frequently coming to us? This gets back to Jesse, your point of practicing what you preach. And I see this all the time of chaplains who are so are giving and life-giving for the people that they're serving, and yet they're not taking good care of themselves, or there is friction on the chaplain staff because they're not treating each other as well as they treat patients. So how do you kind of take a step back and include yourselves in all of this?
Such a great question. I think that one of the ideas of a quote I heard, which resonates with this question, is that self-care is not saying me first, it's saying me too, like me also. And I think that including that the circle can be expanded more. And I think that part of that kind of vulnerability and willingness. For example, in psychiatry training, we have process group, like that idea of a process group, support group throughout, where we are able to share these experiences and be able to work through them. And I think that that type of camaraderie is so revealing and strengthening.
And I'll quickly just ask, thank you. I enjoyed that. You know, when a plane is going down, the first rule is that you put your oxygen mask on first. Then you can help the person beside you. So if you're not taking care of yourself, it's going to be hard day in and day out to take care of others. So start with yourself. Do those mindfulness practices. Take time in the chapel, say a prayer, whatever you need to fuel your spirit, then you'll be able to go out. And it's okay to take a pause and say, I just can't today. I'm an advocate for mental health days. Take a day a month, whatever fuels your soul so that you can give back. But if you're constantly pouring out, you'll be empty and you will burn out quickly. Remember, what will you do with that one wild, precious life you have? Take care of it, because we only get one.
Yeah, I mean, I would just add that we tend to not frame this like it's a benefit to our life. We try to frame it more like a crisis intervention, right? Like something's wrong, I have to fix it, instead of I don't want something to be wrong in the first place. And I think that's what's really important about this, which is like when we take care of ourselves, hopefully we won't get to the thing being wrong in the first place, right? And that makes it easier for us to do our jobs and keep up with all the other aspects of our life. If we frame getting therapy as the only way is to, solve an issue that is an actual crisis, as opposed to it makes me better at my job. I'm better at my job because I talk about what's going on in my life. I'm better at my job because I meditate, because I sleep, whatever. That's the problem. So it's a framing issue, I think, is like we've really just looked at mental health from the crisis end of the spectrum instead of the whole end of the spectrum, to be able to say like, listen, I'm a lot better if I do yoga when I'm just a little tired, instead of I need to do yoga when I've like missed 4 weeks of work because I feel miserable, right? Like someone will punch you in the face if you suggest it then. So it's like, how do we frame it within the context of this spectrum, to realizing that it makes us better at our job. It doesn't make us worse. It makes us better leaders. It makes us better providers. It makes us better parents, better friends, better whatever aspect of your life, insert blank here. And it's a reframe, and that's hard. And nobody told us to do that, and they were wrong.
I agree, and I would add that like I think that not like there could be a tendency or pressure, especially I've seen in training, where it can feel like people compare sleep deficits or how many days on call have you been on or things like that as an almost badge of honor, when really it's depleting them internally. And so how do we, even when we speak or make jokes or make comments, to be very mindful of what we are championing with our language.
I just want to make one more appeal. If you all have any final parting resources, actions you'd like us to take, whatever it may be, I want to make sure all three of you have an opportunity to let us know.
Come to my book one. It'll be fun. I'll send you books like Oprah. I'm a good Oprah. It'll be a lot of fun. But I'll put the link in the chat for 30% off, because in my opinion, if you sit and listen to me for this long, you should get the discount, because you deserve it.
Yeah, for my call to action, I'm not sure how many of you have seen this book. It's a personal gem that my sister introduced me to. It's a book called Crucial Conversations. There's many authors on it, Joseph Grenny, Carrie Patterson, Ron McMillan, Al Switzler, Emily Gregory. The book basically gives context, tools, language to be able to restore safety and stay in communication with others, even when, and especially when it can be challenging. And so it's a great read. And I each page, like I stop at because I'm trying to implement. And so if you're interested, I'd love to, talk more about it. But thanks again. And I look forward to staying connected to you.
I just want to say thank you to everyone. I saw in the chat that several of you have questions about RISE. Get in touch with Michael. He'll get in touch with me. Happy to give you more information about RISE and Brave Spaces. And in my spare time, I love to read Dr. Naomi Riemann, Kitchen Table Wisdom. There's so many nuggets in there that helps you day in and day out to do the work that we do, to help us to continue to be resilient. Resiliency is not a fix. It's just something that helps you to bounce back. You may not be able to fix the system, but you can work on fixing you, that you can be sustainable in a very complex system. Thank you and God bless.
All right, Sarah, you want to close us out?
Absolutely. Thank you so much to Michael and our incredible panelists for just a very rich discussion. I am just going to end with two other call to actions for all of you. The first is I will share a link in the chat and we will put a QR code up on the screen. I invite you to join our Faith and Health Collaborative, which is a group on LinkedIn. It is a growing network of providers and practitioners and educators in the intersection of faith and health. And it's a space where we continue to share resources and opportunities, and just a space for stories and connection. So please do join. And finally, we encourage you to check out the Chaplaincy Innovation Lab's next webinar titled, let me pull this up right here, Atheist Chaplaincy and Death Row, on June 13th. So I will share the link right here as well as follow up. And we'll discuss atheist chaplain Devin Moss, who will share more about his service to a fellow atheist condemned to die. So again, it'll be on June 13th at 1 p.m. Eastern. Just again, thank you to all for joining our webinar. We are excited to host another one shortly this fall and just look forward to continuing discussion. So thanks so much, everyone.